This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
All right, welcome back to another Owens Recovery Science Podcast. This is Johnny Owens. I'm here with Kyle Kimball and Zach Dunkel from our group. And today I'm super excited, super excited, because we're going to talk about something with BFR that we get so many questions about. I've been trying to get studies going for a long time in this population. And so we're going to talk about BFR and its potential application in pediatrics. And so we have some folks here that are from some really esteemed institutions, from Children's Healthcare of Atlanta, as well as Connecticut Children's. And not only are they kind of some of the top centers for pediatric care and pediatric ortho care, but they also have registered clinical trials that are starting up, God willing, if COVID allows us, with pediatrics post ACL reconstruction. So from Connecticut Children's, I've got Adam Weaver here, and also, man, Nick. You told me your last name. I'm gonna work on it. I'm a Texan, man. We don't have many Italians down here. So also from Connecticut Children's, we have.
This is when we need Ben to do the pronunciation.
Did I do it well? Was that
Jam
good enough?
Petruzzi.
That's perfect. Sounded great.
Jam.
Man.
It sounded awesome.
Nice accent on there too.
Smith.
Yeah.
Right.
Now we know. He thought Zach was a kid. He told Zach Smith.
Yeah, and he goes by Smith. And then let me find the rest of I lost my notes. Sorry. And then also from Children's Healthcare of Atlanta, I've got Jeannie Graff on as well. And Jeannie, I got to ask you, you're a UNC undergrad, so you got that UNC blue in you. And then seriously, you went to Duke Fellowship after that? So did UNC, did they just disown you after you decided to go be a Dookie?
No, I didn't do the fellowship, but I worked where
you worked there.
The resident and the fellow work. I did my last clinical there, and they offered me a job. And then I met my husband there too. So you can see that behind me, that Duke sticker. So
you're a Duke house now.
Oh no. Okay. You should see this house in March. March Madness this year. Great year for it to get canceled. Carolina was tanking. So
yeah. Well, at least something good came out of it. So, and I also kind of want to highlight your institutions. So, Children's Healthcare of Atlanta is just this massive, amazing institute from everything I've read about it. You guys are both, in the, ranked as U.S. News and World Report's one of the nation's best children's hospitals. You guys have 3 hospitals. You have like 700 beds, do tons of patient visits a year. And so, if anyone's going to do a study, we would like to see it come out of a place that just has that kind of reputation behind it. Same thing with Connecticut Children's. It's the only pediatric hospital in all of Connecticut focused solely on pediatrics, and also ranked in U.S. News and World Report. So two just big time institutions, which is cool because, man, we get hit up like almost weekly, if not every other day, by groups that want to do research and ask us questions about doing a blood flow restriction. But the biggest thing is, what's your history of the research, and can you get the enrollment numbers in? Nothing kills a good study like enrollment not being there. And so you guys being from some institutions that they can actually get it done is pretty cool. So Jeannie, you want to kind of talk about Atlanta Children's Healthcare of Atlanta and just what you guys do there, how long you've been there, and kind of highlight it a little bit?
Sure. Yeah. So I've been there since February 2018, after I moved down to Atlanta, and we have 12 clinics throughout the metro Atlanta area. I don't know if you guys know much about Atlanta, but it's a very spread out city. So I think that's a huge strength for us, is that we have an excellent orthopedics department and great surgeons, and we have a lot of arms kind of reaching out all across Atlanta, where we can give those patients that see our doctors and have surgery with us, give them access to great physical therapy. We have a lot of contracts with high schools and local soccer club, club sports that also just help us reach our community in a bigger way.
And so when you guys do a study, do you focus it throughout all those different satellite clinics as well for follow up for doing the study protocols, or do you have like just everyone comes down to the main center and that's where it's all done?
So COVID's a little unique. The traffic's a lot better right now, but usually
yeah.
traffic is pretty terrible. So that's another reason why us having a lot of different clinics is really helpful. So for the study, we kind of analyzed which 4 clinics see the most ACLs, and that's kind of how we decided which clinics would be participating in the research study. So we're not, just for reliability's sake and limiting the number of raters, we're not going to have all 12 clinics participating. We're sticking with 4.
That's nice though. You know, we have a big femur fracture trial in like Houston, Memorial Hermann. They have to do all their like testing everything downtown Houston, and just getting patients to drive, you know, from Sugar Land, Texas, downtown Houston. It's like a 2-hour trek, even though it's only 20 miles away. So it's nice when you can spread it out and do it that way. What about you guys?
I do know an interesting fact about Children's Healthcare of Atlanta. They have a therapy dog Instagram. Like they have a big therapy dog program.
Great. Their therapy.
Really?
I did a little bit of
how cool is that?
Work in the hospital, and it's amazing.
So actually, funny enough, Jeannie, my cousin has one of those dogs. She is one. I don't know. Is it a handler? Is that what you call them? She works in the education department. She's math, I think. Her name is Ginger Armstrong. But you might not know her, but you might know her dog, Peanut. Like I told her, I'm like, I don't know if you know this woman, Jeannie, but she might know your dog.
I'll have to look for her on the Instagram for sure.
Yeah, but they have an Instagram for their therapy dogs, and that was awesome when I saw that today. It made me happy.
We had therapy dogs at our base, and they had to wear name tags, but they would take the pictures of the dog for their name tag, and they took it like in the same area where we would all get our tags done, and so it's just like a dog, like on the name tag. Always look like they're posing for it.
A literal dog tag.
Yeah, dog tag. There you go, literal dog tag. Yeah. And so, you guys focused in a little bit about Connecticut Children's. How long you guys have been there? Sure. Kind of what it's about.
Yeah, I can start. So as children's hospitals go, we're relatively newer. So Connecticut Children's was established in 1996. So we are kind of a younger institution, and we're continuing to grow. And that's one of the pillars of Connecticut Children's is growth. And we want to reach out to as many patients and families as we can in Connecticut, and then also the surrounding areas. So Western Massachusetts, which is pretty close to us, and then as well as Eastern New York. So our goal is to serve the patients and families of Connecticut, and then the bordering states around us as well. The sports medicine division was established 14 years ago. So we started with one PT 14 years ago, or the equivalent of one full-time PT, and now we're up to 14 full-time PTs. So we're growing. We have great doctors that have worked with us in the past and are working with us now. And it's a really good time to be at Connecticut Children's. I've been there coming up on my 12th anniversary. So I worked at an outpatient clinic in Fairfield County for a year, and then I've been there since. So I'll let Adam kind of tell a little bit about himself, but it's a place that really fosters growth. And one of the things when Adam joined us, he saw the potential that Connecticut Children's has. And then we've been working really closely together doing research for several years now. Our clinic structure, we have one main hub where everything kind of started. That's where the majority of our patients are seen out of. But over the past 2 years, we've expanded into other areas. So we're on the right in Hartford, where the main campus is. Our sports medicine hub is Farmington, which is about kind of 10 miles outside of Hartford. And then we're on the other side of Hartford as well. So we're starting in that area, and then with a goal to expand and reach all the kids in Connecticut.
Nice.
Yeah, and so I've been with Connecticut Children's almost 4 years, but been practicing 15, almost 16 years. I'm originally from Maryland, so that's where I grew up. That's where I went to PT school. So we hate Maryland, and we hate Duke and in North Carolina, even though they're in the Big Ten now. So no hard feelings there, but we're just jealous that we're not North Carolina or Duke. So my background, I sort of worked in private practice for almost 10 years, and I spent 5 years sort of in a cash-based practice prior to coming to Connecticut Children's. So coming on board, and there's just a great opportunity, the way we work pretty closely with our docs and our staff, with everything being in one place. And I think kind of at this point, we're seeing anywhere from 75 to 125 ACL surgeries a year, just in that sort of ballpark. We've had some surgeon turnover, so that's changed a little bit. So that's kind of been we've had good support as far as trying to allocate time as a full-time clinician, which is difficult, but good support as far as getting the time to try to navigate all the things that go into doing some sort of clinical research from that standpoint. So we kind of see obviously a lot of lower extremity issues, but primarily knee stuff right now, ankle. We were seeing a lot of upper extremity, shoulder and elbow stuff, but with surgeon changes, obviously how that will change things. But the hub of the majority of our post-operative care is certainly ACL and patellar instability, which is just a huge chunk of pediatric, if you want to call that sports medicine, but pediatric orthopedic care from that standpoint.
And you guys are tied into UConn, right?
We're not. We're independent. So we're located next to UConn's campus, but we are independent children's hospital. So
okay. One of my good buddies who worked with me at the Center for the Intrepid, he's a professor at UConn now, and I'm a consultant on an NIH grant for, I never can get the name right, Ehlers-Danlos syndrome, using BFR in that group. So they might be tying in with you guys, I think, because you all have the patient population if we get it funded. So cool. Well, let's kind of move into the blood flow restriction talk here then. We'll stay here on the Connecticut side. When did you guys start thinking about trying this, and how long have you been doing it there? And kind of give us a little background on your thoughts on blood flow restriction in pediatrics.
Yes, I guess I can take that. So I initially sort of was exposed to stuff from a good friend and colleague of mine, Jeremy Baxter, who was now with the Houston Texans. Yep. And when he was at Northwestern, he kind of sent me some papers. This is 2013 or 14, and said, "Hey, you got to check this out." And that sort of started my sort of personal sort of just study on and reading into things. And then when I came to Connecticut Children's, Nick and I started having more conversations, and we really started to try to push just to educate our docs to say, "Hey, what do you guys think of this?" That took quite some time. That took probably a year or two of multiple journal clubs and sort of just kind of pestering surgeons and pestering the people that handle the money from that standpoint. And then, so I guess last spring around this time was when Zach came up to teach our whole staff. So that was in, I think, May of 2018. So we've had about a full year now where we're using it daily, for not every single patient, but a large chunk of patients.
Nice. So once you got to buy it, it just kind of started to just go with it.
Yeah, I mean, we had pretty good surgeon. One of our main surgeons was really in support of it, and once he sort of said, "Hey, let's go for it," we kind of hit the ground running from that standpoint. And so I think Nick and I were talking earlier today. I think we probably have in the last year close to anywhere from, we don't have an exact number, but 700 to at least 700 or to 1,000 treatment sessions in the last year, just of patients. That's a rough estimate. So from our surgeons that are in-house with us, we really don't have any issues as far as, they will tell us if you say, "Yeah, we don't want you to do this," based on a medical condition. But otherwise, they are trusting of us of using it as needed.
And one of the things you asked was, when did you know you wanted to study it? So when Zach was presenting, there were a lot of questions from our group, just people saying, what is there in the pediatric population? Can you educate us on that? And Zach's answers were, there's not much out there yet. So once I heard that kind of threw the flag up in my head saying, hey, let's do this. Adam touched on journal clubs, and one of the doctors that we worked with, he pretty much challenged everybody to do things. So if you asked a question, you pretty much sign yourself up for it. So I was thinking in my head, I was like, hey, let's do this. Let's figure out a way to do it. And then by the end of the day, Adam, Zach, and I were talking about potential of getting this going. So once we knew there was an opportunity, we wanted to take that opportunity because we obviously believe in it. We think it's beneficial, and we've been treating ACLs for a lot of years, and there's all testing out there, and we've done some research on that, but we know that those people have deficits. We need to find a different way to do it, and this is one of the avenues. We want to investigate it a little bit more.
Yeah, and I think I want to highlight that when we get to a little bit, the recurrence of ACL injuries, especially in pediatrics. You know, the PTOA aspect, post-traumatic osteoarthritis aspect of it, protecting the meniscus, everything else, and maybe how I think we can help this. Jeannie, how about you, your institution? How long have y'all kind of been implementing it, and what have kind of early numbers, if you have it, or anything like that?
Yeah, so I first heard about blood flow restriction actually when I was still at Duke Sports Medicine, and our resident at the time, Sarah Parker, gave a grand rounds presentation on blood flow restriction. I was like, wow, this is really cool. And I think Duke actually, they purchased some blood flow restriction units right after I moved to Atlanta. So man, I just missed it. And yeah, I was talking to one of our surgeons, and he was really on board, and I ended up applying for a research grant, the Dudley Moore grant through Children's Healthcare of Atlanta's hospital system, and that allowed us to purchase units for all of our clinics, in addition to a assistive technology fund. But we actually were probably the last group. Were we the last group, Zach, to get trained before COVID?
The last group. Yeah.
It was like March 14th. I was like, yeah. We're doing it, Zach. We're doing it, right?
Yeah.
It's happening.
That was the thing. I mean, it was like, I'm local, we can get everyone there, and let's just knock it out and do it. Yeah.
Yeah.
I was at Disney World trying to hurry up and get back home. So I was just as freaked out as y'all were.
Yeah. So, we really haven't been using it very long. I actually took a course back in August 2019 as I was working on the project, but the rest of our staff didn't get trained until March. So, we're still implementing it and still getting used to it. But from we've been using it on a lot of post-operative patients primarily.
Cool. So I guess let's get into that now. What's the youngest age that you guys can think of that you've applied this on?
Probably 12 or 13.
Yeah.
12 or 13. Okay. Yeah, that seems to be, everyone's around the 12 or 13. The youngest that's been reported is 7. And we actually just had another 7-year-old. We got a picture of her with it on her arm for a broken arm. I don't know how you can get a 7-year-old with a broken arm. Yeah, she was a trooper. She had her thumb up with the cuff on her arm. So we've seen very young. But yeah, it seems like 12 is what we typically hear on up through that range. And so we'll get into your studies a little bit, but I think your inclusion criteria is 12 to 18-year-old. And that's kind of the sweet spot, I guess, of the ACL post-op Chelsea is within that age range.
Yep. Yeah.
So let's go to tolerance. How is it with the kiddos whenever they're trying to do BFR? Are they squirming like barbecue kittens, or are they handling it like champs? Are they tougher than my daughters are when they do it?
I think we were really I think like everybody, we're all a little bit hesitant at first, like how are they going to tolerate this? And then as soon as we started, we realized we weren't giving them enough credit. They probably handle it better than we do. And for most of our post-operative kids, we're starting post-op day 4 or 5, depending on when we see them, usually within the first week. And we've had very little pushback as far as, no, I can't do this, or it's too painful. Sometimes using, Russian stim is probably worse for them than that. So I think for a lot of our therapists, once we got over a little bit of that sort of hesitation, we actually realized we were not pushing them hard enough. And, as you guys have usually alluded to, progressing the load is important. And so that's really been a point of emphasis for myself with a lot of our other therapists, is we've got to make sure you're pushing them as hard as they possibly can. And that's probably the challenge at that age, is when they're, especially the 12 and 13-year-olds, is difficulty understanding what's pain, what's discomfort, because it's usually the first time they've had any sort of major injury or sort of something where they've got to deal with that. So, but we've had very few that have actually said, no, I can't do this. This is terrible. I want to stop. So maybe we're really good, or maybe we're not doing something right. So.
No, I think you are.
I think so.
No,
The kids. We got everybody all at once. That was awesome. No, go ahead. Nick, go ahead, man.
I just think Adam doesn't turn it on. That's probably why.
He's doing the ultrasound fake.
Yeah.
He's doing
with
sham.
the BFR.
Adam's sham. That's
What
actually
about you, Jeannie? How have you seen with the kids?
Yeah, no, I want to echo Adam. I don't think that we were giving them enough credit, and all of our kids have been tolerating it really well. And I actually polled my staff, because just to get an idea of how everyone else is doing with it, because, we don't see each other in person anymore at staff meetings. They're all calls and stuff, but the kids really like the challenge, especially the ones that have just had surgery. It can be pretty frustrating, especially when they're used to exercise being a lot more challenging and more fun. And this gives them a very concrete goal. And a lot of kids have been very competitive with themselves. They want to do better than last time. And when you can turn a straight leg raise into a competition and not just this really boring thing where you're laying on the table for a few weeks doing that, I think that's huge, because I think it's really tough to keep kids motivated in that early post-operative period.
Yeah, for sure.
Yeah, I think, I was just going to say, I think that's the thing that both when I taught both those courses, and even like at Akron Children's as well, the question is always like, man, this is really uncomfortable for us. Like our patients, our kids aren't going to tolerate this at all. And I think that the biggest thing that I tell people is it's the same with geriatrics. Everybody has this default that a 60-year-old, a 70-year-old isn't going to be able to tolerate because the 36-year-old can't.
I was going to make that exact point, Zach. It's the same thing.
Yeah, it's really the same thing. Yeah. And I said, you got to give people the opportunity to prove themselves. And that's just really what it is. Don't sit there and judge the person and say, Johnny, it would be the same thing as, as soon as we play that video in the course of the guy with the Taylor spatial frame external fixator, I lead into that. And I'm like, you're going to see this guy do some things that you're going to immediately be like, I would never do this with a patient. And I'm like, but you have to give them the opportunity to show that they can't do it. Let them prove it. And then I think it's just like Jeannie said too, with people, you've taken a straight leg raise. It's a pretty meaningless exercise, and just it's so boring for people, but now we make it challenging. And it's almost, we simulate this gym environment, and we put them on the path to recovery, and they can actually feel like they're working out in the gym, and they're getting a work once they're done with the session, they feel like they just worked out, versus like, yeah, okay, I just feel like I did some straight leg raises and then, put some stim on my leg and I'm okay.
Yeah. And I think now, not just you guys, like you said, Akron Children's, Andrews Children's, Kenny Krieger, Hopkins, there's a lot of children's institutes now that are doing it. And we keep getting these same reports. Like, they're fine, dude. Get over it. They can handle this. I've never really worked with kids, so I don't know. All I know, again, is my own kids here. I do remember years ago, I had a clinic that was doing it. They called and said that their dad wanted to talk to me about it, to make sure everything was okay. First, before they would do it, they wanted more information or whatever. So how about from the parents aspect? Do they pretty accepting? I mean, you guys are obviously experts and professionals, but have you had any pushback or anything from the parents side?
I was thinking.
Oh, go ahead, Adam.
I was going to say, I was thinking about that today, and I can't think of any times where parents have said, no, we don't want to do this. And maybe it's the way we're just presenting it and making it sort of, they just somewhat know it's sort of the standard of care. But, usually we just will describe it as, it's a blood pressure cuff on the leg, and we're trying to trick your body into working harder than it really is. And then once they hear that, they say, okay, do whatever you got to do. From that standpoint, we've had some pushback from some of our outside physicians. Not I wouldn't even say pushback. It's more just saying, well, we don't have enough evidence yet in the pediatric population to support this, so let's hold off on it for now. But most of the parents sort of just say, oh, that's pretty cool. Let's do it more. From that standpoint.
Cool. And just to highlight what Adam said, we really take a lot of time and want to educate the patient and the family. So going into it, it's not like they just come in and we throw the cuff on and all right, let's do it. We spend time with them. Like Adam said, we get them pretty quick after they have surgery. So within 3 to 4 days, they're in the PT clinic. And we may not do it that first visit, but we'll plant the seed and do some education, and then say, all right, if you guys want to go and look this up, that this is something that we think is going to be really beneficial for you, and give them some reasons why. So we've done education there. And then as we talked about before, we definitely have that great relationship with the docs that we work it with, and they feed into it as well. So they're letting them know there's patients that would have gone to other PT clinics based on geographical location, but they end up coming to us because they sell them on, all right, you can't get this somewhere else, so it's worth it for you to drive X amount of miles or be in traffic for this long because we believe in it. So I think that's been extremely helpful for us to get those patients and families to buy in.
I think the physician conversation is always kind of interesting, Adam. So I'd be curious, all of you guys' perspective, because I think probably what has been said to you is a pretty common response that we hear. Oh, we just don't have enough evidence or this or that. And I think for me, when people are asking me questions about this, I'm like, look, it's little kid muscle versus adult muscle. Is the muscle that different? Is the system so different that there are these added risk factors? But I wonder, if you've had circumstance where you've actually been able to kind of talk to the physician and them kind of hear what sort of evidence is out there, how this technique is being used in adults, and they've kind of come full circle and gone, okay, or has that just kind of killed the conversation when they say we don't have enough evidence?
I mean, I think it's come from more so a lot of the work that you guys have done, as well as the research that's being published, especially in the orthopedic surgeon groups, that it's much more well known now, and so it's seen more, and so it's a little bit easier. They say, oh yeah, I have heard of that, or we were just I can think of 2 surgeons where they said, yeah, we just read on it, and they're kind of on the fence, and then I maybe have sent them a couple articles that reference something, sort of an overview from that standpoint. But I do think there's so much research that's being published, and it's more commonplace at least in the Academy of Orthopedic Surgeons seems to be there. So in the big journals now, so people know about it, that especially in sports medicine. So that makes it a little bit less difficult, I think.
Yeah. Cool. Jeannie, Nick, y'all have any experiences on that side, or?
again, since we're pretty new to it, we've primarily been using it with our only with all of our docs are on board, and that's primarily who we've been using it with up to this point. So I think as we continue to use it, we'll be obviously having those conversations with some outside surgeons and physicians.
Cool.
Other than a lack of studies, which if there's not studies, and you guys have done the best thing you can do is said, okay, we're going to step up and be the ones to do the studies. But is there anything that anyone's put out there or that y'all can think of that would be a concern in pediatrics? Early on, we were talking about doing a pediatric trial and getting some DOD funding, and it was all about the physis, and like, well, what's it going to do to the physis? What's it going to do to the physis? And we were really like, nothing, we don't think. It's very similar to lifting a heavy load, and the kids are allowed to do that. So we had a little IRB pushback on that. But anything you guys can think of or have heard from someone of why a pediatric wouldn't be able to do it?
The physis is the main thing that I've run into.
Yeah.
Even in, so we're all, we talked about before, members of PRISM. So even in discussions with the rehab interest, the rehab research interest group, we've talked about it, and even among people that are all in pediatrics, that was one of the questions. Are you using it with skeletal immature, or are you just doing skeletal immature? After I got back from the meeting, I emailed Zach and I said, I know there's a lot of concerns out there. And we had talked about it before, that we don't know what those concerns, where those come from, but it can be more fear of the unknown. Just like you said, Johnny, the way that people are going to have those physeal injuries are going to be from compression and shearing, and they're going to be doing the same exercises. It's just with the cuff or not. So I don't know how it's going to really affect it. That's just the way we've kind of attacked it.
I wonder I was just going to say, I think that was the thing I said to Nick when he emailed me. I was like, well, what are the specific concerns? Because if we have specific concerns and we can address the concerns, but if it's just like, well, I don't know if I want to do it because of the physes, I'm like, well, what are we concerned about specifically with the physes? And then from there we can look at it, because, and Nick, I think I sent you like the position stand from the NSCA that was like, as long as it's a well-structured, monitored resistance training program, it's perfectly fine. And in fact, we think it's advantageous and healthy. So yeah. And I mean, completely different, when you're talking about maxing out doing 1RMs versus someone, doing a knee extension at 20% of 1RM or a leg press, whatever the issue may be.
I wonder if y'all would just take a moment, a little bit off topic, but tell us what PRISM is, because I think a lot of our listeners have no idea what it is. I actually have no idea what it is, so it's kind of selfish. But tell us, one of y'all describe that for us, if you would. Jeannie, you describe it. You haven't talked recently, so you have to do it.
I wanted to.
I've tagged you with it.
So PRISM stands for Pediatric Research in Sports Medicine, and it's really cool because it's a multidisciplinary association so there's surgeons, athletic trainers, physical therapists, PAs, NPs, all across the board. And so, and that's where I met Nick and Adam this past year. And I think we're in our 7th year for the annual conference. And Atlanta actually hosted it last year, and then this year it was in Arizona. But it's really awesome. It's a great conference, and there's a lot of great research being presented, and we're growing. So it's a great thing to be a part of.
And PRISM abstracts are due in like 2 weeks, guys. Just a reminder, okay? So get them going, all right? Cool. I forgot what I was about to say on that. Oh, we were going to try and look at the physis issue at our animal lab, and my Siri keeps going off. And little bunnies' physes will fuse in like 6 weeks, And so they were going to try and do some sort of BFR protocol on these little bunnies' hind limbs and see if it made their physis fuse too quick. But a little bunny's hind limb is too much like a muffin top. When they put the tourniquets on, it just like squeezed it. It was like they couldn't get the tourniquets to work right with those little fat back legs. It was like the cutest study of all time, but the Air Force guys couldn't get the tourniquet to work right. So they were going to switch to baby lambs because they have more like just linear long limbs, which is still a cute study, but it never went anywhere. But if you guys want to look for an animal study, don't do the bunnies. The tourniquets just don't work, we found out. So I think one thing I want to kind of move into then is I did grand rounds years ago at HSS, and I think one of the surgeons that was the most excited and talked to me a lot afterwards was their pediatric surgeon, and his reasoning was just the sequelae of these type of injuries, and the re-rupture rates post ACL in adolescence, the post-traumatic osteoarthritis that you see, PTOA after ACL reconstructions, can be up to 87%. When you look at just degenerative arthritis, in people over like 45 years old, it's only like 20%. So these young kids, they have an ACL, they have the bone bruise, they might have meniscal damage, and the surgeons do everything they can to put it together. And then these kids go back weak, and next thing you know, 5-10 years later, they have post-traumatic arthritis. So did you guys kind of want to discuss that in your population at all, of what you see, your concerns, and how you think BFR might be applicable for those problems?
One thing I was thinking about as I was thinking about tonight is I've had patients, especially those that have had patellar realignment procedures, where they might have one and then they'll have another when they're done growing. And that kid's thigh is just tiny, and it's just going to be tiny for, had been years, and he just wasn't getting that muscle bulk back. So, if we can find that this does help our pediatric patients, especially for those kids that have a surgery so early, if we can get that satellite cell production and actually give them a chance to hypertrophy that muscle again, I think it's going to be so huge.
Yeah, I think a lot of people are like, kids just heal, they'll just get better, just rehab them and they'll get better. And I think they all probably are going back with a deficit. Sorry, Nick, I cut you off, man.
No, that's all right. I just want to add on to what Jeannie said. When we were trying to figure out the population that we were going to work on, the patellar instability, the postoperative patellar instability was another group that we're looking at just for that reason, because they're going to be the people that have the most gains to make. So we ended up going with ACL just because that's something we've researched more often. And then the testing and how you would test a patellofemoral instability patient, a lot of the testing has been done. It's either handheld dynamometry or isokinetic dynamometry. And that, in a person that has had patellofemoral issues for a long period of time, they may get exacerbated, and we don't really know if the strength measurements that they're giving or that we're getting are telling us what's really going on there. So that was one of the limitations with using that population. But we do think from clinical application, that is a huge population that we can affect and have really good outcomes with. And we are seeing that, obviously not in a study, but just anecdotally.
Clinically, you're seeing it?
Absolutely.
What about anterior knee pain? Just regular old patellofemoral pain. Have y'all done it much on that?
Yeah, definitely.
Yeah. I was going to say probably not as much as our postoperative kids, especially of late with just the corona situation, but certainly from just the pain inhibition standpoint, that's been something I've been experimenting is probably not the right word, but using a little bit more with some of these kids that have had long-standing knee pain that has not resolved with your traditional methods of strengthening and other things, because sometimes it just provides a workaround for that. And again, those guys tolerate it pretty well as well, and they're often just desperate, especially if they're an athlete, to try to figure out a way just so that it feels better from that standpoint.
Yeah, and same for you, Jeannie. Oh, sorry. Go ahead, man.
Sorry, I was just going to say, in terms of the, the ACL and just with the meniscal pathologies and any of the other pathologies, the literature is pretty clear just at how much quad weakness impacts everything long term, in various ways, and in the knee joint specifically. So, especially for any of these guys, my thought is if we can influence this earlier on, in this way, and this is a tool that will help with that and restore some level of symmetry, or at least assist it earlier, then that's really important, especially if you're 12 or 13 years old, knowing that, your risk of re-injury is higher, but also your risk of other, whether it's arthritis or other meniscal pathologies to show up. I think this is just really, important. And with our ACLs, part of the reason that it really spurred me into doing the BFR study is, we have all these ACLs, and when we test them isometrically at 3 months, regardless of graft type, regardless of treatment, sort of strength and conditioning protocols, we can't seem to break the average of being a 30% quad deficit at 3 months. And if this is a way to help that further down the road, then I think that's kind of really the, for Nick and I, that's kind of the emphasis of why we've really sort of attacked this in this way.
Yeah, and talking pressure, then you guys are using kind of our standard pressures that everyone 60 to 80% typically. Most of the kids tolerate 80% in the lower extremity. Sounds like.
Yeah, I looked back through our logs, and we've had, so Adam said before, we have almost 700 or maybe more than that bouts or exercise bouts. In our study patients, we have 100 to date, and there were, out of those 100, there were 6 or 8, I can't remember off the top of my head, that couldn't tolerate it. So the 6 or 8 that didn't, it wasn't that they didn't do it, but they just didn't complete the session. During the rest period, they asked to turn it off, or there were they made it through 3 sets and couldn't get that 4th set. But a portion of those we were doing 100% occlusion when they couldn't do either the long or quad. So we had them just do it with a quad set and had 100% occlusion. So that was a couple of them that had tolerance issues, and all of them were within the first 2 or 3 weeks. So we start at 80, and then those people then were backed off to 60 and didn't have issues. So perfect. It is a pretty small percentage of the 100 that we've done so far. It was a small percentage.
Cool. Did we lose Jeannie? She's still on there? Looks like we dropped out.
I think we lost her.
Okay. Yeah. Okay. Well, while we wait for her to get back in, then let's move into your study then. I'd like to kind of highlight what's going on with it as much as you want to talk about it. So you kind of want to highlight what the study is, when you're going to start doing BFR on them, what the progression is, what your primary aims are.
I can take it. So we're using a 12-week trial of BFR. We're hoping to enroll 20 active patients. We have 5 enrolled right now, and we're probably going to use just a retrospective control just based on convenience. And then we're using a similar sort of strength and conditioning or exercise protocol as to what you guys sort of have in your manual. We made some tweaks on based off of what we like better clinically. Our first visit is started within the first week. So that's anywhere from 5 to 7 days out, depending when they come in. And then they will do 3 exercises, 75 repetitions, sort of in the 30-15-15 protocol, twice a week for 12 weeks. And then we test them preoperatively, strength, thigh circumference, outcome measures, and then we're testing them again at 3 months, and then somewhere in their return to sport test between 6 and 9 months. And we really tried to set it up so that we could do it without a lot of disruption in our day clinically, so that we were doing, it really is trying to do what we do on a daily basis and standardize it as much as we could, because obviously research is, as we're learning every day, as clinician researchers, I guess I should say, that it's really it's really difficult. So that's kind of how we've structured it from that standpoint.
And then you're taking out far though. You're going to have 1 and 2 year follow up, right?
Yeah. So we usually, we'll test them anywhere between 6 and 9 months for the return to sport test. That's typically when the surgeon will clear them or not clear them. And then we're going to try to follow up with them at 2 years with a 1 year follow up as well from that. So, and because we're not enrolling a huge number of patients, it'll be a little easier for us to, from an administrative standpoint, to try to follow those patients and keep track of them from that standpoint.
Yeah, so even before the 2 year follow up, you got to hurry up and get an interim paper published to get it out there, to be the first ones, and everyone cites you. So get that one out there first. And your protocol is beautiful. I could go into it super deeply here, but got these kind of 2 week blocks where you slowly increase the activity, kind of keeping the same BFR parameters on it. So I think that protocol setup's fantastic. And it's, if people want more information on it, they can go to clinicaltrials.gov. It's registered on ClinTrials. Just look for Connecticut Children's and ACL trial, and it's on there. Cool. Welcome back, Jeannie.
Thanks.
We lost you for a minute.
I know.
That's okay. So we just went over the study these guys have going, more of a pilot trial, 20 patients, but long-term follow-up. We're going to get tolerance, or we're at least going to get an understanding from a study perspective of, well, subjects tolerate it, and haven't already done 700 plus subjects. I think they already know that they're going to tolerate it, so that's not going to be an issue. Do you want to kind of highlight or go into your trial a little bit of what you guys are looking at? And let me get it straight. This trial, you got funding, and that funding was for this trial, so it's a funded trial?
Yes, it's a funded trial, and it's also registered on clinicaltrials.gov.
Yeah, good. So give us some highlights here. How many you're enrolling? When you plan to see them post-op? What your primary aims are? What you're kind of looking for?
Sure. So our primary aims are looking at quad strength, quality of life, and tolerability. So our department only has one isokinetic machine, and it's way up north in Atlanta. So we are going to be using handheld dynamometry to evaluate quad strength, and then we'll be normalizing that to body weight. And we are going to be looking at the Lice-Holmes score primarily for quality of life. And for tolerability, we're going to be evaluating the patient's discomfort, pain level at the knee and at the thigh at the end of each exercise, as well as their Omni perceived exertion score, which is similar to an RPE, but a little bit more pediatric specific.
Yeah, that's very similar. That's similar to Luke Hughes's ACL trial. BFR was harder at the thigh, but better at the knee. So hopefully we see the same thing with these peds too.
Yeah, I might have read that paper. So.
Oh, okay. I was just saying, It sounds very familiar.
Yeah. And the tolerability literature is pretty consistent across the board. But yeah, I thought it was relevant to look at knee versus thigh. And we're planning on seeing them for a pre-op appointment for baseline strength measurements, as well as a post-op appointment within 5 days of surgery. And then we'll start BFR at the first treatment session if they are in the BFR group. And we'll be seeing them for a minimum of 20 visits in the first 4 months. And we have a bit of a simpler setup with exercise selection and staging. So stage 1 will be a knee extension isometric, whether at 0 degrees or 60 degrees, and a straight leg raise. And then we'll move into leg press and combination of a knee extension isometric, moving into isotonics when our current ACL protocol will allow later on at 10 weeks.
And so should we even go down this wormhole? You guys aren't afraid of open kinetic chain ACL.
Always go down.
Do we want to start that conversation?
Please. Yes.
Zach Dunkel might lose his mind.
I thought that would come up. Yeah. So, I think this is something a lot of surgeons are probably struggling with. And, I'm hopeful that good literature will continue to be produced where, there will be a definitive answer in everyone's mind. I know in some minds it's already definitive, but that's certainly something that we're looking at. And who knows, maybe Nick and Adam's study, they'll have a better isometric strength at whatever time point. It's like, well, they did long arc quad and we did isometric. So, that could help add to that.
What's crazy about theirs is it's like the reverse of what a typical person would do that's concerned about the open chain. Is they're doing open chain early and then moving to the leg press, versus other people are going to do closed chain first and then move to the open chain. It's just, I read that and I was like, this is like so kind of opposite of, the kind of mantra that's put into some people.
You made Zach's day when he read that protocol.
That's good. I'm glad we could do that.
Yeah. Well, and if you're going to do open chain, at least with BFR, you can do it light, and we're hoping to get an effect. So I think that's something. And the quad's so important, we move to functional and there's still a weak quad, unfortunately. And open chain is a great way to get it back. So we did it at the base a ton on our post-op ACLs and weren't concerned with it, especially again, once we started doing BFR. And your 24-week follow is long-term on yours, right, Jeannie?
Yes.
Going out to 24 weeks. Cool. I think Kyle had a problem with your OmniRes.
I do have a problem with it. It pretty much looks like Beach Bum Alice Cooper or something. I've never seen that OmniRes before. I texted Johnny and Zach, and I'm like, this looks like that Furies baseball player from the movie The Warriors, where there's those guys that run around with the baseball bats. Like, it was the weirdest looking picture.
So Zach and I deeply read your protocols, and we're going into it. And Kyle,
I'm just looking at the photos,
like
I look for
on
the
the
pictures and graphs.
Like
that's all I do.
Kyle goes, "What is this? The Marilyn Manson version of the OmniRes?"
I did.
And your trials.
There's a male version and a female version too, which is pretty funny.
Nice.
Oh, nice.
I couldn't tell which one that was. That was the gender neutral one, I guess, that I saw.
Approved for California.
And in both of them, you have starting at 80% LLP is what your trials are going to start at. Okay. And then take it down if they don't tolerate it and just document it, basically. Yeah. Perfect. Anything else on your trials before we kind of move on to some kind of closing questions here that y'all wanted to highlight, or are y'all enrolling now?
Yes. So we have 5 people active right now. And we're continuing to actively enroll. One of the things that I wanted to highlight, and we'll maybe be able to get some information about what happens to the muscles proximal to the cuff. One of the surgeons that we work with is really wants to investigate what happens at the hip. So we've kind of changed. We've modified one of the Chris Powers handheld dynamometry hip extension testing protocols. So we have the patients prone over our isokinetic dynamometer, and we're doing isometric hip extension. So we're looking at that at all our time points. So we're looking at that at 3 months post-op, and then at time to return to play. So we can get maybe a little bit more understanding on what's going to happen proximally with these patients as well, in addition to the kind of traditional knee flexion, knee extension, isokinetic. And then we also have a couple other functional tests that we do in there as well for strength. We do a timed anterior step down test So just as many reps as you can do off an 8-inch step in a minute. And then we have the wide balance in there too. And we're kind of constantly looking at how those tests, what they're telling us and how they're related to other things. So we're trying to continue to learn on that, but those are included in this protocol as well.
Yeah, and you have that hip extension test as well, right? Not the hip extension, the bridge test in there as well, which will maybe show us something kind of close chain proximally, the whole chain.
We're also looking at hip AB and adduction strength and hamstring strength. I just went over our primary outcome measures, so that'll be interesting to see what we find there as well.
It'll be huge. So if you get a positive PEDS trial and you get proximal thrown in there as well, you guys will be like on the conference lecture circuit for like the next 2 years, talking about proximal changes to the cuff and pediatrics. Two of our biggest questions that we get all the time, but that would be huge. Are you guys using BFR for proximal conditions currently? Shoulder or hip?
Yeah, we're using it in shoulder and hip post-ops as well.
In post-ops. Cool. You guys as well at Connecticut?
Yeah, I mean, more so the shoulder than the hip at this point, just based on our numbers of where our patients are. I was just going to say one other thing: for our study, our primary graft is going to be quad tendon, and so we have two surgeons, one that's using an all soft tissue quad tendon, and then one that's using a quad tendon with a bone block. So as we go forward, we may sort of be able to see we'll be able to look at some of the quad tendon just as it compares to some of our other retrospective. We have a lot more hamstring data. We have a pretty growing body of quad tendon data in this population. So, and right now we're not seeing much of a difference as far as a lot of our other numbers, but that'll be sort of a secondary we'll be able to see some things that certainly will make our surgeons happy as well too, just in support of the quad tendon.
Yeah, is that a trend in pediatrics going to the quad tendon away from hamstring?
It's certainly regional, I think, in the Northeast, at least. I mean, maybe we're so insulated with our surgeons, but it seems to be, at least in some of the conferences at PRISM, and there was a lot of research presented on quad tendon surgical techniques, as well as just some of the short-term gains, long-term sort of outcomes. And there's not a lot of long-term outcomes yet, but some of the long-term outcomes are still comparable to the other graft types at this point.
It's pretty rare that I see a non-quad tendon ACL in Atlanta.
Huh. Very interesting. Cool. Anything else you guys would want to put out to people that are thinking about BFR and pediatrics? Last pearls, thoughts? Trust the kiddos. They're tougher than us. They can handle it.
Yeah,
Tell them.
Don't be afraid.
If you show them a few videos of professional athletes using it, they'll be right on board.
Yeah, good. Okay. Well, we have a lot of those nowadays.
And I think I'll just kind of reiterate what Jeannie said before. In my experience, people that have done it and are competitors and athletes, they love it, and they're coming back asking for it. And unfortunately, we've had people that have gone and torn a second ACL, and the first time we didn't have BFR, and they just report that things the second time are going a lot better. They attribute it to BFR. Obviously, being through the rehab before has a huge impact on that as well. But from a strength standpoint, we've seen some pretty good results with that group of patients that are kind of returners or either contralateral or secondary ipsilateral injuries.
Sounds like you got a second study there, man.
Cool. Zach, Kyle, any other questions you guys have?
I got another question for Jeannie, since she's in Atlanta, and years ago, Jeannie, you have no idea this, but you may have heard us talk barbecue on the show before, which inevitably I'm going to bring up. It's going to go to Texas, going to go to barbecue at some point if I'm on the microphone. And so Zach swears to me that Georgia barbecue is every bit as good as Texas barbecue, Kansas City barbecue, all this, and he does know his barbecue.
What was said. It was superior.
I'll give you.
It was superior.
I'll give you. Okay, he says it's superior, but this is my experience. He sends me a recipe for barbecue sauce that was basically a bottle of Jack Daniels, a teaspoon of salt, a teaspoon of pepper, and a tablespoon of molasses. And that was the barbecue sauce recipe. So my initial read on Atlanta barbecue, Georgia barbecue is poor. What's the barbecue like in Atlanta? That's my question.
Guys, I'm still on the North Carolina vinegar barbecue train.
That's
where I grew up. I'm a vinegar barbecue girl.
Yeah.
I can't even tell you about
Pork
Atlanta
and
barbecue.
Vinegar.
We do vinegar in Georgia. Yeah.
We do. Good.
Yeah.
I haven't had it yet.
We do. You go to
Doused in
Alabama.
Jack Daniels.
I mean, Kyle, not everyone likes vinegar. You got when you serve barbecue, you typically invite people over. You know, not everyone just orders Wagyu.
Yeah, I'm elite, baby. I'm barbecue elite,
right?
Zach. What can I say, man?
yeah, exactly.
It's Wagyu left brisket every dang day.
Yeah, I don't think Myra Mixon's ordering up Wagyu brisket. Okay.
So these guys could go on for hours, so I'm going to cut them off there. Yeah, especially the Connecticut guys, having to listen to this.
Yeah, they're going barbecue.
Lame barbecue talk.
Yeah, we don't have barbecue here. We barely have food.
The only sauce I know has meatballs in it. So
yeah, I was going to say just all Italian up there. Cool. Well, thanks, you guys. This is awesome. Super excited to see these studies go and keep us updated. It'll be great to see at Prism next year or so, at least kind of an update on how the trials are moving along. So,
where is Prism next year? Y'all want to plug that real quick?
Houston, I think.
Is it? Okay.
Yeah.
H-Town, baby.
Yeah.
Y'all can get some good barbecue in H-Town, Connecticut, boys.
Yeah.
Perfect.
You go to Killins out in Sugar Land. You go to
if we can get there.
Yeah. That's true.
We might be presenting it virtually.
It might be virtual all over again. I know.
Yeah.
Cool. Well, thanks, everyone. Appreciate it. Stay in touch.
Thanks,
Thank
guys.
you.
Thanks for having us.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.